We're a little bit behind, so I think I'm trying to adhere to some kind of schedule, but the dirty secret is we can always make up for this at lunch and in my renal grand rounds cases. So the relevant disclosure here is I am a consultant occasionally on advisory boards for ZS Pharma related to ZS9. So I'm going to go through hypokalemia and hyperkalemia today, and just to give an overview, I want to talk about some of the new developments in regulated Kayexalate by the distal nephron. Not all of these are really clinically relevant yet, but I do think it's important to let you know about what's happening in the literature. One thing that I think it's very important to talk about is the role of both the renal and adrenal RAS in K homeostasis, and talk about we tend to forget about the role of adrenal K sensing in potassium disorders. We'll talk about hyper and hypokalemia, urinary indices, and other diagnostic tests, clinical consequences, treatment, and differential. So we'll try to go through everything in less than an hour, which is challenging. The key issue with potassium is that it's only a very minor component of total body potassium is the serum potassium or the extracellular fluid potassium. And there's tremendous interplay between mostly muscle potassium and serum. Muscle in turn plays a big role actually in potassium homeostasis and protecting serum potassium or plasma potassium from being excessively elevated. There is potassium excretion in the stool. We don't tend to talk about it, but we'll talk about why that's now become a bit more clinically relevant. The majority of potassium is secreted by the kidney, however, and we'll talk about that in detail today. This isn't advancing. In terms of the interplay between plasma potassium and muscle, you're all familiar, I think, with these factors that regulate transmembrane potassium shift. Insulin will tend to increase uptake. Beta catecholamines, mostly beta-2 catecholamine receptors, increase uptake. Alpha catecholamines, however, decrease uptake. Acidosis tends to decrease uptake. You see that with metabolic acidosis, but only non-organic metabolic acidosis. So it does not occur with lactic acidosis and ketoacidosis. Alkalosis tends to increase uptake. With hyperosmolality, you get an efflux of potassium through unknown mechanisms, really. So giving a big slug of mannitol or a slug of other hypertonic solutions can cause a hyperkalemia. As we said, the bulk of potassium is secreted by the kidney. Approximately 65% of potassium is reabsorbed by the proximal tubule, another 25% by the thick ascending limb, and there is a potassium recycling by the thick ascending limb. But really the business occurs in the connecting tubule before the collecting duct. That's where the bulk of regulated potassium secretion occurs. And K secretion goes up in the setting of potassium intake with recruitment of K channels. Aldosterone and vasopressin also increase K secretion. Increases in flow also will increase it. However, K secretion is dramatically downregulated in the setting of low potassium intake or actual hypokalemia. And in the setting of potassium loss, you also upregulate potassium reabsorption in the outer medullary collecting duct and intermedullary collecting duct through HK to PAs. The picture I want you to have in your brain when you see patients at the bedside is again that of the principal cell. Here, though, we're talking about its role in potassium reabsorption and sodium absorption. Chloride is not absorbed to significant degrees by principal cells. It's absorbed by adjacent beta intercalated cells through the anion exchanger pendrin. So if you have a sodium absorption through ENaC, that generates a lumen potential positive difference of a negative potential difference. And ENaC, of course, is the amiloride-sensitive epithelial sodium channel. That drives K secretion through two major flavors of potassium channel in the principal cell. ROM-K, or the renal outer medullary K channel, which was cloned many years ago at the Brigham by my mentor, Steve Hebert. It's the baseline low conductance secretory K channel. There is also a flow-activated K channel called BK, or big kidney channel, or maxi K channel, that also can play a role in K secretion. But it's this relationship between sodium delivery, the generation of a lumen-negative potential difference, and potassium excretion that is incredibly important in all aspects, really, of potassium disorders. It turns out to actually be a little bit more complicated than that. There is also electroneutral secretion by adjacent intercalated cells that have HK-ATPases as well. So they have many different K channels and can secrete K and absorb K as well. And there are amiloride-independent or ENaC-independent mechanisms for K secretion. But really, for all intents and purposes, that picture of the principal cell really works very well in clinical physiology. It's important to know that potassium is secretion in the collecting duct and connecting tubule is proportional to distal tubular flow. However, you recruit much more capacity to excrete potassium under circumstances of high potassium intake, and that can be drastically reduced under situations of low potassium intake. So if you take animals on a high K diet and take out their tubules and look as to how flow increases can increase K secretion, you get multiple log folds higher K secretion in those animals than you do in the animals that are on a low K diet, where they have down-regulated the K channels. The other very important clinical issue is that sodium delivery to the collecting duct and to the connecting tubule and principal cells is a major factor in the ability to secrete potassium. So that if you look at animals on a high sodium diet versus a low sodium diet, the ability to excrete potassium is significantly attenuated at every level of plasma potassium in those animals. And we see this clinically as well. So that take-home message, you need to deliver sodium to principal cells to absorb sodium and generate that lumen-negative potential difference. There will probably be 3 or 4 questions on the boards on this particular subject alone. They'll give you electrolytes and say, why is this patient not secreting potassium? And the key will be a urine sodium of 10. And clearly the urine sodium delivery is what the distal tubular sodium delivery is what's limiting K secretion. It also limits proton secretion by adjacent intercalated cells, because that's also electrogenic, and that's a subject that will come up when we talk about acidosis and renal tubular acidosis. Aldosterone plays a very important role in setting the stage for potassium secretion, but it's not an exclusively anticholinergic hormone, or cholinergic, sorry. So if you look at animals that have an adrenalectomy and are given 5 times the appropriate amount of aldosterone versus those that are not replaced as adequately with aldosterone, again, you see a significant difference in the ability to secrete potassium at any plasma potassium. There are, however, Aldo-independent and Aldo-dependent factors in K secretion. What aldosterone does, really, even though it's activated by high K intake and plasma potassium in the adrenal, it mostly activates the driving forces for K secretion. So it turns on the amiloride-sensitive sodium channel, it turns on the NAK-ATPase, whereas high K intake and plasma potassium directly modulate the K channel density and the ability to secrete potassium. Causes of hyperkalemia, I think you're all very familiar with this differential. I won't go through it in great detail. But again, intracellular, extracellular shifts are important. And remember, with metabolic acidemia, you get this shift with non-organic acidosis, but not with anti-GAP acidosis. You can also see it with respiratory acidosis, that you get a shift in hyperkalemia on that basis as well. Drugs, of course, are very important, and we think of the renin-angiotensin axis and the ability to inhibit this axis at any step of the way. NSAIDs and COX-2 inhibitors, as we'll talk about, are potent inhibitors of renin secretion, as, of course, renin activity through the renin blocker aliskiren. ACE inhibitors, of course, reduce angiotensin II generation. ARBs inhibit the effects of angiotensin II. There are various different flavors now of mineralocorticoid antagonists. You may see on the boards, you may see a question on drospirenone, which is a component of several contraceptives such as Yasmin. It has mineralocorticoid antagonistic effects that are basically equivalent to 25 milligrams or so of spironolactone. So you can see hyperkalemia from that drug. In terms of the renal tubule, amiloride is, of course, the blocker of ENaC. So, however, is triamterene, and so is trimethoprim and Bactrim, as many of you, of course, are aware. So that's how you can get hyperkalemia from trimethoprim through that mechanism. Pentamidine also blocks ENaC, and there's a Japanese drug that blocks ENaC through a different mechanism called nafamostat. It's very important in our patients, however, to take a dietary history. It's very difficult to develop hyperkalemia exclusively by increases in K intake, although that has been reported, for example, in athletes that are taking huge amounts of potassium supplementation. So really, however, our patients are the other way around. They really have impaired ability to excrete potassium, and even on a normal potassium, relatively normal potassium diet, they can become hyperkalemic. So we can get tremendous utility out of talking to them about what they are taking in their diet that we can restrict. It's not an excessive potassium diet, but it's something we can back off on that can help. And of course, you all are aware of tomatoes, potatoes, oranges as being major culprits. There is, however, a lot of potassium in meats. So, and it's not just what you're eating, it's how much you're eating. There might not be a lot of potassium in watermelons, but if you eat a whole watermelon at one sitting, that might cause a problem, and so on and so forth. I want to talk a little bit about hyporeninemic hypoaldosteronism because I think as I think all of you appreciate, it's the underlying mechanism for hyperkalemia in many of our patients, particularly diabetics. So these patients have a hyperchloremic acidosis about 50% of the time, and their urine pH, however, can be acidified to less than 5.5. They're hyperkalemic, and they have a reduction in plasma renin activity. That's opposed to renin, which is the enzyme that you use to make cheese. They have reduced plasma renin, and they have a reduced aldosterone. And that, however, is physiologically suppressed in most of these patients. You can actually bring it up, but they have less of a response to stimuli such as furosemide or captopril. You see this commonly with elderly patients and with those who have a reduced GFR, and it's classically seen in diabetics for a number of reasons. These are often patients that are hypertensive, and they often have a clinical increase in their extracellular fluid volume, which, as I'll talk about, is actually probably mechanistically important. The causes are multiple. I think diabetic nephropathy we see a lot of. You can see this in acute GN. You can see it in the patients with post-strep GN who come in with hyporeninemic hypoaldosteronism and hyperkalemia. Really, the tubulointerstitial nephropathies are more resistant to the effect of aldosterone. They're not always bona fide hyporeninemic hypoaldosteronism. So we need to talk a little bit about the physiology of renin to understand these disorders a bit better. We need to remember that renin is secreted by juxtaglomerular cells, or granular cells, in the juxtaglomerular apparatus. And the juxtaglomerular apparatus is composed of the adherent tubule with the macula densa, the extraglomerular mesangium, and the afferent and efferent arterioles. So this whole apparatus really is responsible for secreting renin in response to changes in tubular chloride and other stimuli. In the 90s, it was discovered at Vanderbilt University that COX-2 is expressed in the renal macula densa, and it does play a big role in modulating renin secretion, and it's worth talking about clinically. But just understand that COX-2, although we think of it as more the inflammatory COX enzyme, it can be recruited and turned on in the macula densa. So the thought is that in the macula densa, you have chloride sensing through the NAK-cell cotransporter. That'll turn on arachidonic acid release. COX-2 will generate prostaglandins that then diffuse locally and activate cyclic AMP and protein kinase A in the adjacent granular cells and increase renin. So who cares? Well, this physiology is clinically relevant. We do see patients on NSAIDs excuse me, are on COX-2 inhibitors who develop hyperkalemia from multiple mechanisms, but including a hyporeninemic hypoaldosteronism. So this is one of the classic early case reports. This was a woman with CKD from lupus, I believe, who was on Indocin. When she came in, she was hyperkalemia. When she stopped Indocin, they could see that her plasma renin came up, her aldo came up, and her urine aldo came up as the same time as her urine prostaglandins came up. So this is a large part of the mechanism of how COX-2 inhibitors and NSAIDs can cause hyperkalemia. There are other parts of that mechanism as well, but this is probably the clinically dominant mechanism. The other thing that I really want to underline is that adrenal glands also respond to changes in potassium. So the adrenal gland will release aldosterone in response to a change in extracellular potassium. So if you look at the difference between aldosterone secretion at an extracellular potassium of 5 versus 2, it's about a doubling of aldosterone secretion. The other very important point, though, that we don't talk about is that the local renin-angiotensin axis also modulates this response. So angiotensin II turns on some of the K channels that are responsible for regulating aldo release in response to changes in potassium. And angiotensin II synergizes with increases in potassium in turning on aldosterone release. Well, is this clinically relevant? Well, we don't really know that much in humans, but we do know that if we take adrenal glands out of animals that have been pre-treated with inhibitors of the renin-angiotensin system axis, and then we look at how much aldosterone can be released from those adrenal glands, it's tremendously blunted in those animals that have been on an ACE inhibitor or an ARB or related drugs. Hyporeninemic hypoaldosteronism, in turn, as we said, these are patients that will have low aldosterone and relatively suppressed renin to varying degrees. You can always appreciate that not all of these patients fit the example perfectly. This is a terrific case series, or actually investigational case series from Frank Epstein and Barbara Clark in the 90s at the Beth Israel Hospital here in Boston. And they looked at elderly patients who had hyperkalemia from hyporeninemic hypoaldosteronism, and they looked at versus healthy controls who were around the same age. What was striking in these patients is that they all had a tremendous elevation in their plasma ANP. The other thing that they did in this study is they looked at the response of patients or subjects who were old versus young to an infusion of potassium to increase their aldosterone. So in all of these patients, the younger subjects versus the old, you would see an increase in plasma potassium, but the release of aldosterone was blunted significantly in older subjects when they looked. What was particularly cool was if they took young subjects and they co-infused ANP, they completely blunted this response to an increase in potassium. So you see that when you infuse ANP and potassium, you have no increase in the aldosterone. So the ANP is thought to play a really important role in doing two things. It shuts down renin secretion by the kidney, but it also blocks this response of the adrenal gland to hyperkalemia. And it's thought that ANP and BNP play a big role in the physiology of hyporeninemic hypoaldosteronism, where you physiologically turn these hormones on, and that blunts the renin and aldo secretion. So the take-home messages that I wanted to talk about, that ANP, systemic and local RAS, and prostaglandins all affect renal renin release. So prostaglandins also have a role in the adrenal gland in regulating the response to hyperkalemia. And this role in hyporeninemic hypoaldosteronism of volume expansion and increases in ANP and BNP to decrease renal renin, but also to decrease adrenal aldosterone release. And we didn't talk about this, but I think you all appreciate this evolving risk of hyperkalemia from combining multiple RAS inhibitors, e.g. mineralocorticoid antagonists and ACE and CHF. Plus, a significant component of that hyperkalemia that we see is because of this blunting of the adrenal response to hyperkalemia in the setting of a RAS inhibitor. So question 1, you referred a 17-year-old high school student for management of high blood pressure. This is from a case report, this data. He's not seen a physician since childhood, or earlier childhood, I guess, is on no medications. He denies drug abuse, including cocaine. His 50-year-old father is also hypertensive with a history of renal stones, which is a hint. And since you have access to a clinical research center and unlimited resources, you admit the father and son for biochemical profiling while you ingesting a diet with a rigorously controlled salt content. So this is actually the data from this particular case presentation. And you can see that on a dietary sodium intake of 200 a day, both father and son were hypertensive with basically hyporeninemic hypoaldosteronism. However, the whole syndrome melted away when they were successfully put on 10 milliequivalents a day of sodium intake, which is almost impossible to achieve. So, which of the following is the most appropriate therapy for this patient? Case restriction, sodium restriction to 10 milliequivalents a day. Clearly, that's not doable. Nifedipine, amiloride, or hydrochlorothiazide. Any takers? It's E, so it's hydrochlorothiazide. So this is one of those annoying boards questions where you have to recognize the syndrome and actually get to the treatment as well. So this is pseudohypoaldosteronism type 2 or PHA type 2 or hypertensive hyperkalemia or Gordon syndrome, whatever you know it as. This is the mirror image of Gittleman syndrome, which in turn is caused by loss of function in the thiazide-sensitive NaCl cotransporter. These patients are hypertensive. They have a hyperkalemic acidosis versus the alkalosis in Gittleman's. They have suppressed renin and aldo versus the activated renin and aldo in Gittleman's. And they actually have hypercalciuria versus hypocalciuria in Gittleman's, and they also get nephrolithiasis. It's responsive to thiazide. So this is like Little syndrome. It's exquisitely responsive to one particular inhibitor of salt transport. It turns out there are 5 different genes for this disorder, 4 of which are characterized. It's as rare as hen's teeth, so I've never seen a patient with Gordon syndrome, but you will see a question on the boards about Gordon syndrome. The mechanism was discovered in a terrific landmark paper now 15 years ago by Rick Lifton's group at Yale, and they found mutations in the Wnt kinases. There's not a typo there. Wnt means with no lysine. And these kinases don't have a catalytic lysine at the catalytic site of the kinase. So Wnt1 is one of the genes, Wnt4 is another. The other 2 genes play a role in ubiquitination of these and other players in this pathway. Those were discovered more recently. Wnt1 is expressed in the DCT and in the collecting duct. So these are cells that express aquaporin 2, the principal cells. These are DCT cells that express NCC. And Wnt4 is also expressed in the same cells but slightly differently. So these are where we expect to see an effect because we know that these patients are sensitive to thiazides. Long story short, the Wnt kinases are thought to downregulate the NaCl cotransporter. So one of the classic papers soon after the cloning of these kinases was from Gerardo Gamba's group and Steve Hebert and Rick Lifton. When they co-express the thiazide-sensitive cotransporter with Wnt4, you see inhibition of the thiazide-sensitive transporter, and the mutations that are associated with this, or kinase inactivating mutations, blunt that effect. And that single thought that it's an overactivity of the thiazide-sensitive cotransporter turned out to be really, really important. And we now understand that the DCT, just upstream of the connecting tubule, plays a huge role in potassium homeostasis. So the NaCl cotransporter is turned up or down depending on case status through many of these mechanisms that involve the Wnt kinases. For those that are interested, there are many reviews that go through this very complicated signaling, but these Wnt kinases turn out to be a switch that allows us to switch from the K secretory effects of Aldo and to shut those off appropriately depending on K balance. So this is what we call the aldosterone paradox, and I'll go through it just a little bit so that we've gone through these new developments in physiology. So in hypokalemia, you have an increase in angiotensin II that turns out to inhibit the apical secretory channels, the ROMK and the principal cells. You also have potassium-dependent regulation of the NCC, NaCl cotransporter, that is suppressed by hyperkalemia and activated in hypokalemia through angiotensin. So when you want to get rid of potassium, you turn down the thiazide-sensitive cotransporter, so you deliver more sodium to the connecting tubule. When you want to stop potassium excretion, you reabsorb sodium just upstream of the connecting tubule, and you prevent that secretion. There's also electroneutral NaCl cotransport that is a whole other set of transporters that have just been discovered. That has no effect on electrogenic K secretion, so you then absorb sodium without increasing potassium excretion. And as I said, there's a whole host of other poorly described ENaC-independent events in K secretion. Don't worry about this slide, it won't be on the boards. You can still just remember that single cartoon of the principal cell and that lumen negative potential difference as being really critical for most situations in clinical medicine. Hypokalemia, I think you're also familiar with all the various causes. We won't go through the entire differential. So question 2, you're asked to evaluate a female patient with intestinal pseudo-obstruction called Ogilvie syndrome with diarrhea and profound hypokalemia. Her meds include metoprolol, risperidone, insulin. Exam and imaging is notable for signs of colonic distension. She has a potassium of 2.5. She's acidemic with a bicarbonate of 15. And she has a transtubular K gradient of 3 with a potassium in the stool of 100 and stool sodium of 10. So which of the following is the most likely cause of this patient's hypokalemia? Any takers? C. I heard C. This is another boards question you will see because this disorder has only pretty recently been described, or the mechanism for this. So Ogilvie syndrome, it turns out to be a very potent cause of hypokalemia. And there are 3 recent reports, there's not been any further ones really, that identified a novel association between Ogilvie syndrome and hypokalemia due to a secretory diarrhea with an abnormally high K content. One of the patients had concomitant ESRD, and immunohistochemistry revealed a huge increase in upregulation of the apical K channel BK. So this is the patient had a huge amount of this K channel versus the normal amount in a typical patient. So it's thought that in this disorder, probably through sympathetic activation, you massively upregulate this secretory K channel that plays a huge role in the diarrhea, but it also causes direct intestinal loss of potassium. This also may be very important as a mechanism in the hypokalemia that is seen in inflammatory bowel disease, where BK channel is also upregulated. But this is another potential disorder you might see on the boards. So renal loss and hypokalemia, I think you're all familiar with how diuretics will do this, how antibiotics can. I want to underline magnesium inhibition. And there are 2 major reasons how hypomagnesemia causes potassium excretion. One is it inhibits the muscle NAK ATPase, so you have an increase in potassium release from muscle, and therefore you have a kaliuresis. The other thing, though, is ROMK is blocked, usually, in the intracellular side by magnesium. It's an inward rectifying K channel, and part of that is maintained by intracellular cations such as magnesium. So when you have magnesium deficiency, it's been shown very beautifully that ROMK is inappropriately highly active. So you have ongoing K secretion through ROMK in the setting of hypomagnesemia. But it's very important that when you treat hypokalemia, you look for hypomagnesemia and you treat that as well. So hypokalemia and hypertension, as you know, is another syndrome that we need to think about. Commonly, common causes include aldosterone-producing adenomas or bilateral adrenal hyperplasia. Less common are the things that you might see on the board exams: familial hyperaldosteronism, including glucocorticoid remedial hyperaldosteronism, adrenal cortical carcinoma, renal vascular disease, and so on and so forth. So there's been a tremendous flow of physiology in the last few years on the sensing of potassium by adrenal glands. And this is the physiological activation of aldo synthesis by angiotensin II. It turns on K channels that signal and respond to plasma potassium, and it turns on intracellular calcium that then turns on the enzyme that produces aldosterone. In glucocorticoid remedial hyperaldosteronism, you have a hybrid gene where the aldosterone synthase gene is put under the control of the actual promoter for the gene that produces glucocorticoids. So in that setting, ACTH turns on the production of aldosterone. There are, however, you should be aware, this may turn out on the boards, that in adrenal adenomas, there are acquired mutations in the adenoma themselves in a K channel called GIRK4 that changes the sensing of these adrenal glands and basically turns on this depolarization of the membrane and turns on the synthesis of aldosterone in these adrenal glands. And there have also been mutations found in calcium signaling pathways as well. These are acquired mutations. They can also be acquired in the genome in patients that have certain forms of a hereditary hyperaldosteronism. But again, this theme that we're talking about, remember the adrenal gland and how it responds to potassium. And in adrenal adenomas, we now know that that's actually turned on inappropriately by mutations in the sensing mechanisms for potassium in the adrenal glands themselves. How do you look and work up patients with primary hyperaldosteronism? You do a plasma aldosterone to renin ratio. You should check this when the patients are normal kalemic because the low potassium can suppress aldosterone secretion. Beware of drug effects, so ACEs and ARBs will affect this ratio, as will beta blockers. My general experience has been patients with primary aldosteronism, most of the time the aldo will really drive through whatever drug they're on. So usually I won't change the drugs before measuring this. But if I really suspect it down the road and the tests are not confirmatory, I might stop one of these medications as well. You then need to confirm this by a 24-hour aldosterone secretion in the urine. And then you need to do salt suppression testing. You need to either do this orally with 200 milliequivalents a day for 3 days and then do a 24-hour urine, or you can give them intravenous saline and do the pre and post PAC-PRA ratio. In practice, what I do is, it depends on really the individual patient. If a patient has an elevated ratio and clearly high aldosterone secretion, I may do the IV saline suppression test. Some experts recommend doing both, giving the oral salt loading, doing the 24-hour urine, and at the end of that process, bringing them in to do the IV saline. You then need to do imaging and adrenal vein sampling. The issue with the adrenal vein sampling is patients that have an adenoma on imaging on one adrenal gland, something like 1 out of 6 of those patients, it's actually the contralateral gland that is the hypersecretory gland. So it's become really, the Endocrine Society recommendations are to do adrenal vein sampling, except in very rare cases, extremely high aldo or younger patients, or there's certain criteria for not doing the adrenal vein sampling. But in general, you need to do the adrenal vein sampling before sending them for surgery, or now increasingly also considering radiofrequency ablation of an individual adenoma or a particularly unilateral hyperplastic gland. So if we talk about the consequences of hyper and hypokalemia, the effects of hyperkalemia are mostly on excitable tissue, changing the resting membrane potential. And that, of course, plays a big role in the cardiac effects of hyperkalemia, which are listed here. In skeletal muscle, also, you can get weakness, fatigue, and paralysis. And in the kidney, you have a decreased ability to secrete ammonia, causing acidosis. So these are the classic findings that we see. We think about these tall peaked waves, the loss of the P waves, widening of the QRS. However, this, of course, is not really what we see all the time. And we can see patients with hyperkalemia have no ECG changes or variable ECG changes. And there's the old saw. Remember, the first symptom of hyperkalemia is death. It's a great way to scare interns on July 1st. ECG changes are not particularly sensitive, particularly in ESRD patients. You can see peak T waves in other disorders. You should be aware of atypical ECGs in hyperkalemia. You can get conduction blocks, intraventricular conduction delays. More recently, the pseudo-Brugada sign, where you have a pseudo-right bundle branch block and a coved SC segment like you see in Brugada syndrome is also described in hyperkalemia. The treatment of hyperkalemia, as you all know, is three-pronged, at least for now. That's to stabilize the membrane potential with calcium, increase cellular uptake with insulin or beta-2 agonists, and K remover with Kayexalate or some of the novel K binders as they come up, or with dialysis. So we've known for many years that a hypertonic slug of bicarbonate is not very effective at reducing potassium, and is much more effective to use epinephrine or insulin and glucose or dialysis, this classic picture from many years ago. However, particularly now with the issues with Kayexalate, I've been more creative. I will often use isotonic bicarbonate. If you look at some of the papers, if you give isotonic bicarbonate over several hours, you will see a significant drop in serum potassium. So particularly in acidemic patients, I do give isotonic bicarbonate. I consider that an important therapy, and I can usually, in doing so, get away from using Kayexalate. Insulin and glucose, we won't go through in detail. It's usually 10 units with a 50 gram of 50% dextrose. If you use that typical regimen, patients will become hypoglycemic and they should be put on a D10 drip. So always remember that. Never give D50 alone. The hyperosmolality itself can cause acute hyperkalemia before the sugar has had a chance to activate insulin, and it's a great way to get a lawsuit. Beta-2 adrenergic agonists we tend to forget about. Just remember that the dose is approximately 4 times what we use for asthma, so that can be a bit of a delay sometimes. Largely from data with epinephrine, people don't recommend that you use it as the sole agent. It can, however, be synergistic with insulin and D50, so you can use the two together and get a really good drop in potassium. So Kayexalate, what's the problem with Kayexalate? Well, Kayexalate rarely can cause bowel necrosis. And I found this a hard argument to make until we had a case, actually at the Boston VA, where the patient was given 2 doses of Kayexalate and developed abdominal compartment syndrome, but also tremendous amounts of intestinal crystals of SPS. So Kayexalate takes a long time to work. The intestinal necrosis that you see in sorbitol is often a fatal complication, and it's not restricted to the post-op setting. There was an animal model from many years ago that implicated sorbitol, which never really made sense. And a more recent animal model has shown that it's not the sorbitol, it's the Kayexalate that causes the intestinal necrosis. It's still really an important reflex treatment, and I think all of you know that most patients that you're called about by the ED have already been prescribed Kayexalate. So the future alternatives are Patiromer and ZS9, or whatever its brand name will be. Patiromer is now available only though through subspecialty pharmacies, so it's not available in regular pharmacies yet. ZS9 has been delayed by the FDA. ZS9 seems to be a little bit more selective as a potassium binder than Patiromer. Patiromer has an issue with binding magnesium, so many patients become hypomagnesiemic on that therapy. And there may end up being problems with drug binding as well with Patiromer. But we now do have alternatives at least around the corner or even now available for Kayexalate. So in the interest of time, I won't talk about the serum dialysis gradient, but it's there to talk about. Consequences of hypokalemia, the one that I want to underline in particular is hypertension. So if you look at animals that are on a low potassium diet, they have a significant increase in their renin secretion, and on that basis they develop hypertension. The QT interval is prolonged in hypokalemia. This is a case report where I think even I can tell that the QT interval here is longer than it is here. And you can see this nice shortening as potassium came up. Many textbooks will tell you that the QT interval is not prolonged in hypokalemia, but it really is. And hypokalemia is an important cofactor in other causes of the long QT syndrome, be it genetic or drug associated. This was a very important paper, again by Rick Stearns many years ago, looking at the correlation between serum potassium and total body deficit. And when you look at the hypokalemic range, it's actually a pretty linear relationship. So there's a drop in potassium of 0.27 millimoles every 100 milliequivalent deficit. When I see hypokalemic patients, I will always calculate that, not because it's accurate, but just because it tells people, it underlines to people, for a K of 2.5, that's a 500 milliequivalent deficit, and that patient needs that replaced over several days. So treatment, you look for sequelae first. If they have a prolonged QT interval, you are obligated by AHA guidelines to put them on telemetry. If you don't, you may get a malpractice case because they do need to be on telemetry. First, replete magnesium for the reasons that I talked about before. Oral therapy, preferably KCl, should be given. And you replete the deficit over days. You can get this rebound hyperkalemia after a single dose just because it takes a long time for the potassium to be re-equilibrated and taken up by the muscle. You can give it safely IV at up to 10 milliequivalents an hour, but you really need to be in a monitored setting the more aggressive you are. And you should never give potassium in dextrose solutions. It's well described that the dextrose can cause hypokalemia by inducing insulin, and that can actually abrogate and even overwhelm the effect of the potassium that you give it in. So question number 3, this is a 32-year-old Latin American male admitted with weakness and a K of 2.0. This was actually a Brigham case many years ago. He has not much on, his weakness has fluctuated. It's more severe at nighttime. Denies drug abuse, laxative abuse, is on no medications, and he has family history is notable for one sister with thyroid disease. His exam's remarkable only for hypertension, maybe a little bit of decreased deep tendon reflexes, but otherwise normal. This was his blood work, and again, this is a case from the Brigham a few years ago. His blood work on admission showed a potassium of 2.0 with a magnesium of 1.3 and a phosphate of 1.2, and he had an appropriately low transtubular K gradient of 2.0, and he previously had completely normal electrolytes. So again, we know what this is. That doesn't get you the exam question, unfortunately. So which of the following is likely to be abnormal in this patient? Well, clearly TSH level, genetic sequence of the gene encoding the NAKTPase alpha-1 subunit. Well, that sounds kind of scary, maybe. Genetic sequence of the gene encoding a muscle-specific K channel. Well, that sounds plausible. So all three of these seem potentially plausible. The answer, though, is A and C. And the reason to point this out is we now know why patients of Asian origin and patients of Latin American origin have a particularly high risk of hypokalemic periodic paralysis in the setting of hyperthyroidism. And that's that they often have, many of these patients have mutations in a muscle-specific K channel that plays a role in thyrotoxic periodic paralysis through very complicated mechanisms, which we won't get into. But just be aware that we now understand why these patients are particularly predisposed to develop periodic paralysis in hyperthyroidism. The TTKG we haven't gone through. It tends to be poo-pooed a fair amount. It's not a perfect mechanism. You can read our up-to-date card where we talk about that. The K to creatinine ratio is just as adequate, and it helps in patients such as this at the bedside in differentiating the cause. It's usually not that helpful, I don't find, in hyperkalemia. I think the urine sodium is probably a little more helpful in hyperkalemic patients in deciding whether that's a contributing factor for the mechanisms that we talked about before. However, when you're presented with one of these patients with profound hypokalemia from a redistributatory cause, The TTKG can help you separate those patients from renal causes of hypokalemia. So this is a really nice paper from Taiwan where they looked at patients with hypokalemic periodic paralysis, and they looked at patients who had other forms of hypokalemic paralysis that were due to K wasting. And you see a nice separation of those cases based on the urinary TTKG. So that it is helpful at the bedside deciding whether these patients have a redistributive cause. You may ask, well, why is that clinically relevant? Well, it changes the way you treat these patients, because if you give them potassium, they have a very high incidence of rebound hyperkalemia when the episode passes. So there's been a move to give these patients, instead of giving them potassium, to give them very high dose propranolol, because part of the mechanism here is an upregulation of the sympathetic nervous system by the thyroid hormone. So if you give high dose propranolol, you'll see a reduction in serum potassium as well as serum phosphate, an increase, in serum potassium as well as serum phosphate over several hours. And this hypomagnesemia and the hypophosphatemia are also components of thyrotoxic periodic paralysis that we tend to forget about when we look at these patients in the literature. So the take-home messages, I wanted to talk about the regulation of renal renin release and the adrenal aldosterone release. Remember that they both play a big role in clinical disorders of potassium. I talked about the aldosterone paradox that you can now promptly forget because it's not that clinically relevant as of yet. We talked about these new developments in hyperaldosteronism. You may need to brush up on the fact that there are these new mutations in adrenal adenomas that I think are already fair game for the boards. We talked about treatment issues in hypokalemia that we tend to forget in preference of hyperkalemia. And these new K binders for hyperkalemia will be a huge development, I think, in the future. What we didn't talk is how these binders will change clinical medicine. There's the thought that they will play a big role in being able to maximize RAS inhibitors in our patients pre-dialysis. There's also a lot of interest as to the role of residual hyperkalemia in turning on aldosterone in patients that are already on RAS inhibitors, and whether that part of that increase in aldosterone that these patients have can be blocked by K binders, and that's another very important issue to look at with these drugs in the future. So the references here, my Harrison's chapter, Brennan Rector chapter, and also there's several K cards in UpToDate contain many of the things that we talked about here today. Thank you. Any questions? So the question is, for a hyperkalemic patient, is there a spot urine value? There is no absolute spot urine value. It needs to be normalized to two possibilities. For the TTKG, it's normalized to this fudge factor, the K in the urine over the K in the blood, normalized to osmolality in the urine and osmolality in serum. For TTKG, I've forgotten the numbers, it's a TTKG less than 5 or 6. It changes in whatever paper you look at, but it's in the Brennan Rector chapter. There are thresholds where the TTKG is thought to be inappropriately low, and I think it's 6 or 7, below 6 or 7, a TTKG. That's not been well established for the K to creatinine ratio. The K to creatinine ratio has been studied a little bit more in hypokalemic patients, and if we're not using the TTKG that much, it's helpful as well. And again, I think in the UpToDate card or in my Brennan Rector chapter, we talk about the ratios, and I don't have them off the top of my head. In a hypokalemic patient, if they're excreting more than, I think, 15 milliequivalents a day, that's compatible with K wasting if you do a 24-hour urine, but we don't usually do that. Any other questions? Good. So I think we're going on to the next